A very good evening, everyone. I, Dr. Ruchika Gambhir from Team VOH, welcomes you all to another session of our leadership panel on discussing treating and prevention of biliary tract cancers in the current era, which is taken under our initiative Be Clear, a journey from awareness to action and understanding biliary tract cancers, supported by AstraZeneca. In our last panel, where we discussed about the types of biliary cancers, the causes, common signs and symptoms, today we are going to take it a little bit forward and discuss more about the diagnosis, treatment, the patient journey, and how this cancer affects the individual's lives. And therefore, for today's session, we have with us Dr. Amol Patel, who is the Senior Advisor, Medical Oncology, INHS Asvini. Thank you so much, sir, for joining us today.
Thank you.
Next, we have with us Dr. Bincy Mathew, who's a psycho-oncologist working with Manipal Hospitals, Bangalore. Thank you so much for joining us today, Dr. Bincy.
Thank you, Ruchika.
Next, we have with us Ms. Vandana Mahajan, who is a cancer counselor and a palliative care counselor and a cancer coach, cancer survivor. Thank you so much for joining us today, Ms. Vandana.
Thank you, Dr. Ruchika, for having me here.
Next, we have with us is Dr. Anil Kukreja, who is the Vice President of Medical Affairs and Regulatory, AstraZeneca India. Thank you so much, Dr. Anil, for joining in us today.
Thank you, Dr. Ruchika.
And I feel immense pleasure to welcome Mr. Kailash Pande, who is a survivor as well as a cancer fighter, for joining us on today. Thank you so much, sir.
Thank you.
So before we dive into a brief session, I would really like to thank all my panelists for joining in us today and teaching us about or sharing the valuable insights which we are going to learn about from today. So we would like to begin our panel now, and I would like to start the session from Dr. Anil Kukreja. So my question for you would be basically that how can the healthcare system, the society, and the pharmaceutical industries collaborate together to improve the outcomes and to bridge the gap for the patients which are diagnosed with these kind of cancers? Over to you, Dr. Anil.
Thanks, Ruchika, and thanks, Voice of Healthcare, for this humbling opportunity for bringing the experts and all the stakeholders to discuss on this very important topic. Overall, the gastrointestinal GI cancers, especially the biliary tract cancers, are the common cancers in our part of the world, Asia area, including in India as well. At at AstraZeneca, we actually are inspired by our purpose and values. Uh, we want to transform the future of healthcare by unlocking the power of what science can do, and not only for patients but for people, society, and the planet. And our purpose is actually we want to really push the boundaries of science to deliver the life changing medicines to transform the patient outcomes. And there are few areas which I felt would be important for all of us, like as you rightly said, the healthcare system, society, and the pharmaceutical industries to collaborate to really achieve this outcomes of the patients. One, of course, is most important is we need to understand the local data, the local research to identify the high risk patients in India. Who are the patients who are at high risk, so that we are able to identify, and this cannot be done alone. Here the healthcare system, society, and the industry have to come together. We can be an enabler, but ultimately the data resides in the healthcare systems, and that's very important. Second is, of course, to attract the global research which is happening, because it's important to learn from the global research, and also to undertake collaborative research. I think I just heard that there are few countries which are very predominantly common where gallbladder cancer is common. Similarly, you have a biliary tract cancer which is probably across, probably in different geographies. And what are the factors which are resulting into predominantly high incidence of this cancer in some of the particular belt, right, in India as well. So it's important to undertake those collaborative research. Third, most important is whatever new advances are happening, how do we accelerate these new advances approval and also adaptation of these new advances in the healthcare system? And definitely society also needs to come forward so that we are influencing all the stakeholders and advocacy we are driving so that these advances are included in the healthcare system. And the most important, as we said, is right from awareness, screening, early diagnosis, so that we significantly improve the outcomes for the patients, not only in India, but also be a role model for the neighboring countries and also for Asia area countries to improve the outcomes, not only in India, but also beyond India as well. So I'll just stop here and maybe there are opportunities again to comment in the subsequent questions.
Sure, sir. Thank you so much, sir, for highlighting this whole mechanism. And also that I appreciate the fact that AstraZeneca is not only looking for improving the outcomes to improve the outcomes in India, but rather also the neighboring countries. As per I see it, when we talk about health, health is not something which should be actually limited to one area. A healthy life, a healthy people is something which should be inherited all over the world. So I really appreciate the vision which AstraZeneca holds behind this whole initiative. And my next question will be for Dr. Amol Patel. That so we would like you to elaborate more about the diagnosis and which we are diagnostic steps which we are using for the BTC and the treatment pathway we follow for the biliary tract cancers.
So, the biliary tract cancer, first one has to understand what Kukreja sir has said. I will just elaborate that first, and then go back to the what is the diagnosis and the treatment aspect of it. People say it's a Ganges belt, but I say it's a sub-Himalayan belt. So, see, the biliary tract cancer is not just one disease of the biliary tract. The biliary tract has multiple areas. In the way we in breast cancer divide the diseases into triple negative, hormone positive, HER2 new disease. Similarly, as per the site, the genomic architectures in the biliary tract differs. As this video is going to be seen by the patients or the healthcare workers or the general population, in totality. So, what is biliary tract cancer first? The biliary tract cancer basically it arises from the a channel which is there inside the liver, and these channels they make a duct, and the duct is carrying the all the whatever the leftover what is the metabolic product which has happened which are happened in the liver and it is transported back to the intestine. So, in the liver, there are small canaliculi which forms the intrahepatic channels, and the tumors which are arising from this intrahepatic ducts, which is known as the intrahepatic cholangiocarcinoma. So, what are the tumors which are coming from the liver inside, or from those the channel aspects of it? It is the cholangiocarcinoma.
Okay.
Same the way the smaller the channels which are united and form a main duct. So there is bile duct which is carrying the bile from the liver to the intestine. So this bile duct, the tumor which is arising from it, which is outside the liver, it is called as a extrahepatic cholangiocarcinoma. And there is an organ just below the liver, which is supported with the liver, and the channels which are joining along with the biliary tract. Whatever the secretions have come from the liver, they are stored in the gallbladder, and time this gallbladder contracts and again sends the whatever the collected bile after concentrating it uh, through the again the bile duct into the intestine. So we have now gallbladder, we have intrahepatic cholangiocarcinoma and extrahepatic cholangiocarcinoma. All these tumors, they are different. Why you have to understand this? Because the topography, the epidemiology entirely differs with the subsite and the biliary tract cancer. In the West, the cholangiocarcinomas are common, and So far, so now, till date, the research has in a blanket fashion, they have included all this subsite tumor together to understand the treatment and the results of this subsite. But more and more knowledge we are getting into the DNAs and the RNAs of the tumor, we have now realized that all these tumors are different, and their treatment also possibly might be different in the future. Again, why biliary tract cancer we are discussing today? This shocking the data from the one of the hospital-based cancer registry from Patna. The gallbladder cancer in Bihar is the number one cancer killer. Number one. Most of our health system are not aware of these facts. At one side, our quality of life is increasing. We have the lifestyle disease cancer, which are going to increase in the future, but simultaneously we have inherent problem with our system at present, and maybe for the many decades from the in the past. The gallbladder cancer remains the one of the very big challenge and a public health issue in the northern states of India. Similarly, when you come down to the from the northern part to the southern state, you find the cholangiocarcinomas are either in the liver or outside the liver. The cholangiocarcinomas are common than the gallbladder cancer. So the overall picture is that the sub-Himalayan part might be starting from some parts of the Punjab, or you go to the other neighboring countries, Afghanistan, go till the Bangladesh, Myanmar, or Malaysia. You will find the gallbladder cancer is one of the among the, in fact, or first three or the five cancers in these territories. These malignancies are very aggressive diseases. If in a stage 4 disease they are not treated, the median survival is just 8 weeks or at max 10 weeks. Most of the patient they present in a stage 4 disease because whatever the tumors, the organ is such a way that the gallbladder is situated just below the liver, and whatever tumors are arising, they all already spread to the liver or in the surrounding organs. Because it is not visible, it is not that painful in the beginning, so the tumor they get detected late. Now let's come to the diagnosis aspect of it. I think we're going to talk about the prevention later. So whenever the patient basically they have symptoms like pain in the right upper abdomen, weight loss of appetite, jaundice, all these features are can be due to the biliary tract cancer. Most of our patients they visit the primary care healthcare workers, and as if the pain in abdomen is so common, most of the time it gets overlooked. The diagnosis get delayed. So whenever you have weight loss along with the pain in abdomen, one must think about the cancer. It basically it's a general cancer symptomology. It is there for the almost all the GI malignancies. And on top of that, if the jaundice has developed, jaundice is basically yellow. The sclera becomes yellow. We all know that. So if such symptoms are there, please get evaluated by the experts. Get your ultrasound done and follow the advice. Do not neglect such kind of alarming symptoms. Once these symptoms are detected and or they've developed, and then comes to the phase of the diagnosis. How do we make the diagnosis? Again, it's very easy for a gallbladder, for a breast cancer patients to have a diagnosis because the lump is palpable. You can examine it. the biopsy can be done easily. Here, such matters are not there. So invasive procedures has to be done by the ultrasound guided methods. So the diagnosis can be established by what we call as the FNAC. The FNAC is basically putting a small needle and getting the aspirate from the tumor tissue. There is always a fear of rupturing the gallbladder when doing the diagnostic procedure. That also the hindrance of making the diagnosis. But the fear is always there that if the gallbladder gets punctured, then again it's a catastrophe. The bile can leak and it can create trouble. So uh, it requires the really the involvement of the expert from where to take the tissue, the FNACs or the biopsies. Biopsy is basically a next step for the FNAC, wherein we take a bigger needle and take the chunk of the tissue and then process in the pathology department and make the diagnosis. Uh, Along with this, there are certain the supporting tests generally we ask are the tumor markers. Tumor markers like CA19-9, they are basically the blood test. The another tumor marker is the CEA, carcinoembryogenic antigen, and the cancer antigen 19-9. These are all the terminologies we use. And these are simple blood tests. If they are elevated, then the diagnosis can be supported and we have a more evidence that there is a cancer if this one of the test is increased, the values are increased. So with this the diagnosis is made, and next come is the basically is the staging workup. For that, either we do the CT scan or we do the PET scan, whatever the available special the modality of investigation in your area. Most of the time we see these days all the cancer patients they visit to tertiary care centers, and invariably everybody gets a PET scan. So the PET CT gives us the general idea that the whether the disease is just localized to the gallbladder or it has spread to the liver or some other organs in the body. On that basis, we basically make a diagnosis of gallbladder cancer. Most of the time, it is almost in 70-80% of the cases, this cancer has already spread to the adjoining areas. So it's very easy to get the diagnosis with the biopsy gun and the diagnosis made. Now, the challenge remains for those patients who have just presented with some mass pain and the mass is detected in the localized region. In such situations, we do not advocate the diagnostic procedure. Here comes the role of the surgeon or the surgical oncologist or the surgeon who has expertise in the management of the gallbladder cancer, wherein after the evaluation of the stage, like we are thinking that it is localized, it is might be the stage 1 or stage 2 or at max stage 3. In this situation, we do not do a diagnostic procedure. We straightway go for the laparoscopic staging first. In that, a tube is placed in your body and the gallbladder is examined and the surrounding areas are examined, and after that if the surgeon feels that it's localized, and then straight away we remove the tumor. We don't take the risk here of doing the procedure for unnecessarily spreading the disease either through the tract of the biopsy needle, or it might rupture the other areas and spread the disease unnecessarily, increasing the from stage chances of making it to stage 4. Because of such anatomical issues involved, is a very structure surrounded by the multiple complex system of the blood supply to the liver, the portal system, the lymph nodes around in that area, then the pancreas in the just beside that. So there's quite two challenging procedures are involved, and I suggest those surgeons who are very experienced in such a clinical field or in the surgical field of gallbladder or the biliary tract cancer, they should be looking after such patients, because because as surgical oncological principles are very different, as you might have gained about what I said. So it's not just simple that making a diagnosis and make a FNAC or biopsy. These days, many patients, they insist their own procedures. So don't go by this. Please listen what your doctor is telling, what is your surgeon is telling to you after the plan has made. So follow these advices. So with this, we have understood in largely about the stages, and the treatment aspect is whether the stage 1, stage 2, or stage 3. We first operate the patient, get the disease out of the body, and give the chemotherapy as adjuvant therapy. In the adjuvant therapy, there is again a lot of the data for capacitabin. We call it as a BILCAP trial. But again, one has to understand that this trial has been done in the Western population, and the trial represented the cholangiocarcinoma patients more than the gallbladder cancer. The gallbladder cancer trial as such, we don't have much data. So the institutional protocol might change. Some people might favor to give the capacitabin. Some patients, some doctors might give the gemcitabine cisplatin, which are the two most active agent in the adjuvant setting. What we call it adjuvant. Why? Because the surgery has removed the tumor, and now whatever the micrometastasis disease are there, cover it or treat with the your chemotherapy aspect of it. Capacitabin is also chemotherapy, but is given in the oral form. Now come to the stage 4. After many decades, what the research innovation, immunotherapy has got some place in the management of the biliary tract cancer. So along with the gemcitabine and cisplatin, the drugs which we basically use for management of the tumors, there are a lot of research have come from AIMS, Tata Memorial Hospital, in the management of the gallbladder cancer as such. But now we have one more avenue along with these tumor to treat the patients with the immunotherapy. So we can use the immunotherapy molecules like durvalumab or pembrolizumab for managing these patients. So it was these drugs which have changed the landscape of the gallbladder cancer or the biliary tract cancer management after almost 2 decades of the intensive research. So we didn't have a single path-breaking research in this field because of such a molecular heterogeneity and the inherent tumor resistance of these patterns of the gallbladder cancer. Having said that, with this patient, if they progress in the first line setting, then we give the second line chemotherapy. There are various agents like irinotecan. There is a study from the TMH again, led by the Professor Otswal and his team, the Anantarana Swami, and also the study was supported from AIMS under the leadership of Professor Sharma. So they also come in that come with those trial and showed that in the second line setting, some drugs like injection irinotecan, they do help such patients. But very few patients, they reach up to the management for the second line setting or the third line. Like chemotherapy given, tumor progress, when you give it for the second again time, we call it as a second line chemotherapy, and that's how the second line, third line, and fourth line chemotherapy we use. There is a lot of scope of managing these patients with the genomically guided. We at our hospitals have done multiple studies in managing the gallbladder cancers with the tumor specific therapies, including ERBB2 mutations, wherein we use the lapatinib kind of a drug. So there's a lot of avenues and a lot of research is going on, and in future, possibly maybe another 5 or 6 years, we will find this biliary tract cancer, especially the gallbladder cancer, a very, very treatable disease. So recently, the way we treat the breast cancer, that is HER2 positive disease. Similarly, in gallbladder cancer, this HER2 positivity is around 10 to 15%. In our series, it was 18%. And we used the trastuzumab with the gemcitabine way back in 2017 and 18. And now the trial has come from the TMH, which supports our finding too, that the trastuzumab, the targeted therapy with the gemcitabine cisplatin in HER2 positive gallbladder cancer, yes, it is working. So there are certain positive things which we are getting into the field of the molecular genomics and the targeted therapy. There are a lot of things to offer these days on the basis of the next generation sequencing reports also. With this, I just want to conclude here that the gallbladder cancer is our problem, is the problem of the maybe the India and especially the northern India. Also, the sub-Andes countries, like the way the Himalaya is there is in South America, the Andes, like the country of the Chile, Ecuador, the some parts of the Brazil, the gallbladder cancer again in the is the number one cancer killer in Chile. So there is also a rampant problem. So I think we are going to talk about the preventive aspects of it later and the screening part of it later. But this is in nutshell what I would describe. Though I take, I believe I have not take much longer time, Dr. Ruchika, but that
No,
is
no,
what I
sir.
think that the general
Sir,
community must
actually, it was
understand
quite,
about
yes.
the biliary tract cancer or the gallbladder cancer.
Sir, it was actually quite insightful, and thank you for kind of throwing light on, shedding light on every aspect which needs to be understood before understanding what the diagnosis and treatment are. Thank you so much. That was really insightful. And thank you for explaining it in the easiest possible way. And moving on now, since we have already understood from Dr. Amol that the therapies and the diagnosis, everything leaves an impact on the human body as well as on somewhere on the mental health. So now my next question will be for Dr. Bincy Mathew. We all understand that every disease leaves a impact on mental health, whereas this cancer is expected to leave a deeper impact on our health. Even if a person gets catches cold, it still leaves an impact on our health. On our mental health gets affected whatever we do. So we would like to understand from your end that how this cancer, how any kind of cancer rather, affects the mental health and why during this time it is important to look after one's mental health. Over to you, Dr. Vinci. Ma'am, you're on mute.
Can you
Yeah,
hear me now?
please go ahead. Yeah, please go ahead.
Yeah, thank you, Dr. Ruchika, for this question. And before that, thank you, Voice of Healthcare, for inviting me. And thank you, Dr. Anil sir and Amol sir, like for explaining the biliary tract in a detailed way. So coming to the question, so generally speaking, so what is the first thing that comes to our mind when we hear the word cancer? It's like a threat. Okay, so the fear which is so rooted in people's mind. Okay? And when some people, like most of them, when diagnosed with cancer, they feel their life has come to a sudden halt. And basically, because nobody is really prepared to face such situation in life, right? And there is this fear, uncertainty, and lot of emotions like swirling around. And we need to understand that no matter how strong we think we are, the initial moments, like will likely shake you really hard. And of course, it is going to be different person to person. And some of the common feelings when somebody is diagnosed with cancer, that is like shock, denial, anger, there will be sadness, pain will be there, then guilt, like numbness and depression. And it is completely normal to feel helplessness over what is come next. And it is completely normal and natural to feel sadness also. But when our morale is down, okay, our spirit is broken, things start go in a downward spiral. And these emotions changes so fast within a short period of time. And so if we, like if the people get so caught up taking care of their physical health, they just focus on the cancer, and majority of them, they just neglect the emotional aspect also. Sometimes it willingly or unwillingly, or sometimes like intentionally or unintentionally also, and which leads to a point where you may have trouble in sleeping, eating, and even doing your activities of daily living. And according to scientific studies, generally, like there are like around 65% of cancer patients experience psychological distress, and if it continues, okay, without getting adequate right support or right remedy, it may lead to long term psychological or physical health issues. Okay. And like it is a heavy burden to carry with worries about the future, the because of the diagnosis, the impact on the relationship, the financial aspect, and the physical discomfort that is getting because of the treatment. And if you look at the studies, like in patients with cholangiocarcinoma, so 75 to 80% of patients experience depression and anxiety, and they may there are like it shows that poor quality of life also, and it is impacting their activities of daily living. Okay, so cancer not only affect the body physically, but it take a toll on the mental health aspect. So, and we need to understand that each patient is unique, and their problems are also unique too. From people to people, each phase of their treatment would throw uh, different challenges at them. For example, some people do better at the beginning, but may have tough times during the treatment phase. Okay, and some may do it like a beginning would be the toughest for some people. Okay, and these situations can lead them to feel severe psychological distress, and if we do not provide the right support, okay, it may leads to anxiety or depression, and which is quite common. Okay, the symptoms like they may feel sleep disturbances, anxiety will be there, increased heart rate will be there, irritability, like they don't feel like doing anything, lack of interest. So these symptoms were going to be there. Apart from that, because of the continuous treatment, because of the change in appearance, they may feel low self-esteem, lack of confidence, adjustmental issues, PTSD, and there are a lot of psychosocial issues, which is a lot of people in India would not even talk about. And honestly, there are many of them. Okay, and one of the common issues after the treatment completion also, they face the constant worry about whether the cancer is going to come back or not. Okay, and we call it as like fear of cancer recurrence or uncertainty about the future. And many people find it so difficult to make major decisions during these times. It could be about their career or marriage also. And in some cases, even the family members, okay, they are in complete denial, and that makes it very tough to take timely decisions about treatment. So these are some of the psychosocial issues that we often see. And also we need to understand, since I have talked about the family, when somebody is diagnosed with cancer, it's not only affect the individual, okay, but also the whole family, where for this reason, like many people call cancer as an uninvited guest also. And coming to this cholangiocarcinoma, like, and also the moment when patient search on the internet, okay, it says that the disease is little serious. Okay, and the chances of recurrence and that uncertain feeling. Okay, and even I have a patient with a condition, like he is actually after the treatment right now, he's like off treatment, but he is hyper vigilant about what is happening on him. Okay, he was, because of that, he was unable to sleep, constantly thinking about something is going to happen. And because of that reason, the doctor referred that patient to me. And also there is another case, after the diagnosis, like he joined a social media platform which was led by the few existing survivors and cancer patients, where they discuss the tips and resources, which is good actually. But however, like whenever there is any sort of reoccurrence happen or something inevitable happens, right, so they post it in the group. Okay, after reading this post continuously, it started affecting him. Okay, so he was experiencing heaviness and a lot of somatic symptoms like continuous pain all over the body, headaches. So there are cases like that. So we need to understand that things have changed in the last few years, and because of the advancement in the treatment and because of the technology and like the genomic profiling and immunotherapy, targeted therapy, we have the survival rates are improving. But also we need to understand that one size fits all approach that doesn't work here. And in addition to that, and also I need to say that the patients and the family needs to understand the importance of the emotional health, and it's important to give the importance to the emotional aspect. And um, sometimes if we do not give right, like it will lead to some other psychological issues, and it will make difficult to cope with the treatment, make any sort of decisions, and maintain relationship also. And one more thing I need to say, that our mind and body is connected, it is intertwined and interconnected. It's like a fine-tuned machine. Each part plays a very important role, and so it works together. So if one string is out of tune, it affects the entire composition. So during the treatment, we need to identify, like, it's very important that the emotional health is really important. And when a patient comes to me, like, for the therapy and all, we try to identify the issues and address them as quickly as possible. And during the therapy, what we do is, like, we identify their strength and weakness by looking at their personality, their belief system, their value, the way they look at the world, and we consider these important aspects, and we try to help them to cope up with this situation in a much better way. And one way we need to understand that the fear of cancer recurrence is also one of the this thing, and we need to focus on things that we can control. Okay, so whether you don't have the control whether the cancer returns, so instead of that, we need to focus on what you could do, support yourself in other ways. And so by doing this, we will get, like, we are able to focus more on the treatment, and by then it will provide a better quality of life during the tough times. And by taking emotional help, okay, it is proven that it will significantly improve the resilience and adherence towards the treatment, and by that, overall quality of the uh, patient and the family members. So I want to tell that it's very important to give equal importance to the emotional health, so that we will achieve a better quality of life during the treatment period.
Thank you so much, Dr. Bincy. That was actually great. And I guess I'll have to agree to this thing that our mental health as well as our physical and social well-being, everything is actually connected to each one thing or the another. Once a person gets physically affected, it definitely affects the mental health and the social well-being, and that the goes the same way the other way around. So thank you so much for explaining this all to us and what all kind of things which come up to be in the patient's mind because of this cancer. Uh, Thank you so much. Moving on, now we would like to understand from Ms. Vandana Mahajan about the palliative care. We do understand that palliative care is another important aspect when it comes to any kind of treatment, especially when it comes to the cancer patient treatment. So, Ms. Vandana, if you could just explain us a bit more about what is palliative care and why is it important in cancer patients. Over to you, Ms. Vandana.
Thank you, Dr. Ruchika. Thank you for addressing a very, very important and integral part of cancer treatment. What palliative care is not, I'm going to start with that. Palliative care is not end of life care. Sadly, it still continues to be associated with end of life. Palliative care is, again, not end of life care. Palliative care is essentially a multidisciplinary team which works towards improving the quality of life of a person who's been diagnosed along with the family. So I'm going to talk of Mr. Kailash. Kailash ji. I'm going to take your example. First of all, Kailash ji is not a patient, right? Kailash ji is a human being, is a wonderful man who's been diagnosed with cancer. There are a lot of other things that define Kailash ji. So when we talk of palliative care, we talk of Dr. Amol being there to treat the symptoms. We talk of Bincy being there to treat the psychosocial impact of the disease. We address the spirituality quotient also. I'm sure Kailash ji at times must feel why this happened to me, why me, where did I go wrong? So we address the spirituality quotient, and also it also involves addressing the additional issues like financial issues. So we have social workers working along with Bincy, Dr. Amol. I'm there as a counselor. Social worker also plays a very, very important role. So basically, it is a multidisciplinary team, which ideally should be integrated with the main treatment plan at the time of diagnosis. Sadly, that doesn't happen in our country, Dr. Ruchika. So when any patient, any person, any family is given a diagnosis of cancer, at the same moment, a palliative care team should be involved in the treatment plan. It doesn't matter what the intent of the treatment is. By that, I mean, it could be that the cancer is curable or curative, or the cancer cannot be cured but be controlled. Now, when I say that, we generally, a lot of times, people fear the word palliative treatment. They feel that they're going to die. It doesn't mean that. In cancer, when we say palliative treatment, it means the treatment is being given to control the symptoms, to keep the disease under check so that the quality of life of the person diagnosed is maintained. Palliative care also means the scope of palliative care is very, very large. So this is one aspect. Palliative care also includes people at an end of life, taking care of them, people who are in hospice or people who are progressing towards death. Palliative care also means supporting the caregivers, because we need to understand, like you said, and I think Bincy also said, cancer is not a disease of one person. It affects the entire family, right? Therefore, it is while we take care of the person diagnosed, we've always got to remember that the caregivers take an equal hit emotionally, physically, financially, professionally. So they need to be supported. That is also included in palliative care. And unfortunately, if the person diagnosed dies, then palliative care also includes bereavement. So from the time of diagnosis till bereavement, and it sometimes it also means helping a person, the caregiver who's left behind, to find a meaning in their lives, helping them find a purpose, helping them pick up a job, training them, giving them various options how they can upskill themselves. So the scope of palliative care is huge, and it is very important that in oncology community this is understood. Unfortunately, a lot of people are referred for palliative care only when the disease has reached a certain point and the treatment options become limited. That is when they're referred for palliative care. So I hope, and Kailash ji, you are a wonderful human being with a disease called cancer. A lot of other things qualify you, and we are so grateful that you're here with us to share your experience.
Thank you so much, Ms. Vandana. That was actually amazing. And as you have already highlighted, Mr. Kailash is not just he's a wonderful person. Definitely, we agree to that thing. And before we actually get into understanding the patient journey from a doctor's or a third person's perspective, I would like to welcome Mr. Kailash to share his own journey. मिस्टर कैलाश, हम आपसे ये चाहेंगे कि आप हमें, मैं डॉक्टर से तो मैं कभी भी पूछ सकती हूँ कि आप पेशेंट कैसा फील करता होगा, उनके लिए तो या मेरे लिए तो वो सारी चीजें मेडिकल है, बट मैं आपसे जानना चाहूंगी कि आपने ये पूरी जर्नी जो करी, जो मुझे भी पता है आसान नहीं हुई होगी आपके लिए, उस समय आपने बहुत सारे इमोशंस देखे होंगे, बहुत कुछ फील किया होगा, तो हम चाहेंगे कि आप ये थोड़ी सी बातें, यही सारी चीजें हमारे साथ थोड़ी सी शेयर करिए, ताकि हमें सुनने वाले और जो कैंसर फाइटर्स हैं वो आपको सुन के थोड़ा सा हौसला उनका भी बढ़े। तो प्लीज कैलाश जी थोड़ा सा हमें अपनी जर्नी के बारे में थोड़ा सा कुछ बता दीजिए।
धन्यवाद सभी पैनलिस्ट ने जो ज्ञानवर्धन किया उसका मैं बहुत आभार व्यक्त करता हूँ कि काफ़ी काम हो रहा है कैंसर के ट्रीटमेंट में और नई नई रिसर्च हो रही है, कंपनीज कोलैबोरेट कर रही हैं और ग्लोबली आल्सो द रिसर्च इज बीइंग अट्रैक्टेड, ऐसा सुनने में आया मुझे इस पैनल से, जो कि एक्सपर्ट्स हैं तो अपडेटेड रहते हैं। जहाँ तक मेरी जर्नी का सवाल है तो पहले शुरू हुआ गॉल ब्लैडर, जैसे आप बता रही हैं कि मैं बिलोंग करता हूँ सब हिमालयन बेल्ट से, तो वो तो कैंसर तो मुझे बहुत लेट डायग्नोज हुआ 59 ईयर्स की एज में। तो हुआ इस तरह से था कि जैसे डॉक्टर बता रहे थे अमोल कि गॉल ब्लैडर में लोग ओवरलुक कर देते कई चीज़ें, वही मैंने भी किया। राइट साइड में पेन होता था मेरा, तो उसको मैंने सोचा कि ऐसे ही होता होगा। तो लेकिन जब ये बढ़ने लगा फरवरी लास्ट 2023 में, तो उसके बाद जो है मैं डॉक्टर से मिला तो उन्होंने बोला आपके गॉल स्टोन्स होंगे, ज़रूर ऐसा मुझे लगता है। तो फिर उन्होंने अल्ट्रासाउंड कराने के बोला, रिकमेंड किया। तो अल्ट्रासाउंड किया तो उसमें गॉल स्टोन्स थे। तो उसके बाद फिर MRCP भी करा, ERCP जो भी टेक्निकल टर्म है आई डोंट नो। तो मैं ऑपरेशन के लिए डॉक्टर के पास गया था गॉल ब्लैडर के, तो उन्होंने जो भी प्रोटोकॉल्स होते हैं वो फॉलो करके और टेस्ट किए, तो उसमें पता चला कि मेरे जो बाइलरी डक्ट है उसमें एक स्टोन है। तो पहले उस स्टोन को निकाला, क्योंकि गॉल ब्लैडर रिमूव करने के बाद सम फ्लो हैज़ टू बी देयर। उसको निकालने के बाद फिर उसमें एक स्टेंट डाला प्लास्टिक का कि वंस ये गॉल ब्लैडर निकल जाएगा तो उसको फिर हम निकाल देंगे। लेकिन पता चला कि वो स्टेंट तो फिर काम ही नहीं किया, वो फिर से कोलैप्स हो जा रहा था। तो लिवर फंक्शन टेस्ट कराए तो बहुत ज़्यादा, तो उसमें थोड़ा सा पता चला कि इस तरह का प्रॉब्लम है। तो उसके बाद उन्होंने सजेस्ट किया कि आप जाओ और हिंदुजा हॉस्पिटल में एंडोस्कोपिक ये प्रोसीजर्स कराओ। तो उसमें और गॉल ब्लैडर के लिए जो उन्होंने बायोप्सी का वो निकाला था वो भेजा था उन्होंने लैब में, लेकिन लैब ने मिसडाइग्नोज कर दिया उसको। 6 मंथ तक पता चला कि वो मिसडाइग्नोज रहा। तो जब हम पहुँचे हिंदुजा हॉस्पिटल, वहाँ पे पेट स्कैन वगैरह, एक्चुअली उन्होंने ये सजेस्ट किया था कि आपका, क्योंकि ये पेटेंट हो नहीं रहा है, पहले उन्होंने एक स्टेंट डाला था उसमें, मेटल स्टेंट, उसके बाद रिमूव करने के बाद भी वो ठीक नहीं हुआ, तो उन्होंने बोला कि हेपेटिको जेजुनोस्टोमी करनी पड़ेगी। तो 2 नवंबर को हेपेटिको जेजुनोस्टोमी होनी थी, उसके लिए सर्जरी थी। तो उन्होंने सर्जरी किया, तो उसके बाद पता चला कि वहाँ पर तो एक एडिनोकार्सिनोमा है, तो एक्सप्लोरेटरी सर्जरी बन गई। फिर उन्होंने पेट स्कैन कराया, FN वो जो भी फ्रोजन बायोप्सी कराई, उसके बाद वो सैंपल मंगाया उन्होंने जो बायोप्सी का भेजा था दूसरे लैब में, तो उसमें तो क्लियर था कि देयर इज़ आई मीन डिमार्केशन। तो उन्होंने अपने यहाँ किया, फिर टाटा में भी मैंने दिखाया तो वो क्लियर था, तो मिसडाइग्नोज हो गया 6 मंथ्स। तो उसके बाद फिर उन्होंने जल्दी से बोला कि आप ये ट्रीटमेंट करना शुरू करें, आपको कैंसर है। तो फिर तो कैंसर का नाम सुनते ही आपको पता है कि लोग अभी भी इसको डेथ सेंटेंस समझते हैं, जबकि काफ़ी प्रोग्रेस हो गई है इस फील्ड में। तो बड़ा इमोशनली ड्रेनिंग रहता है, फाइनेंशियली रहता है, साइकोलॉजिकली रहता है, फिजिकली तो ऑफ कोर्स रहता है। पूरी फैमिली इम्पैक्ट हो जाती है आपकी, पूरा ऑल ऑफ अ सडन यू गेट अ शॉक ऑफ योर लाइफ। तो वही हुआ, वाइफ तो मेरी बेहोश हो गई। तो
बट
जर्नी इस तरह रही। और बहुत वैसे बाद में फिर ट्रीटमेंट होता है तो फिर ये तो बहुत ही व्यक्तिगत चीज़ें होती हैं। किसी में हेयर लॉस होता है, किसी में अल्सर्स हो जाएंगे, किसी में बहुत सारी और भी चीज़ें हो जाती हैं। लेकिन मेरे केस में जो गड़बड़ हुई है वो अप्स एंड डाउन जो हुए, मुझे मिले ना हो गया। अब फिर ये ब्लीडिंग होने के बाद 2 बार ऐसा हो गया, तो फिर 2 बार उसके लिए एडमिट करना पड़ा। कल मैं हॉस्पिटल में था, वहाँ से डिस्चार्ज होके आया हूँ। तो अभी वही जो व्यक्तिगत समस्याएं हैं वो बहुत ही इंडिविजुअलिस्टिक होती हैं, बाकी तो सभी परिवार तो पूरा हिल ही जाता है, हर तरफ से जाता है। हम अपनी चिंताएं बढ़ जाती हैं, हम कितना ही स्ट्रांग बनने की कोशिश कर रहे हैं कि इमोशनल एक्सट्रीम हो ही जाते हैं दिन में कई बार। तो सब लोग यही बोलते हैं कि पॉजिटिव रहो, अदरवाइज डाउनवर्ड स्पाइरल ऑफ इमोशनल नेगेशन विल बी देयर, नेगेटिविटी विल बी देयर, विच विल फर्दर एग्रेवेट द डिजीज। तो ये सब चीज़ें हैं। जो सजेस्ट की जाती हैं वो फॉलो भी करते हैं, लेकिन ह्यूमन बीइंग हैं, अपने इमोशंस होते हैं, फिर वो भी इंडिविजुअल इमोशंस होते हैं, कोई ज़्यादा इमोशनल होता है, कोई कम इमोशनल होता है। फ्यूचर की एंजाइटी तो होने ही लगती है कि क्या होगा फैमिली का मेरे, क्योंकि हम भी सोचने लगते हैं कि ये तो डिजीज़ ऐसी इतना ईजी नहीं है। लेकिन फॉर्चुनेटली पेट स्कैन मेरा हुआ था 3 कीमोज़ के बाद, तो उसमें डॉक्टर सेड कि आई एम मोर देन सैटिस्फाइड। So that was a very, turning point about being optimistic. तो ये जर्नी चली रही है, बहुत ही उबड़-खाबड़ जर्नी है, मैं कहूँगा ये स्मूथ जर्नी नहीं है, बहुत ही ऑफ रोडिंग हो जाती है ऑल ऑफ अ सडन खुद ही, तो बड़ा टफ हो जाता है। तो बहुत समस्याएँ आती हैं, स्पेशली फाइनेंशियली यू फील वेरी ड्रेन्ड because the cost of therapy, if you had immunotherapy, it becomes very high and you cannot go beyond the doctor's suggestion. If doctor is taking care, you have to have full trust on the doctor. तो वो ट्रस्ट हम मेंटेन करके रखते हैं, हम उनको ही भगवान मान के चलते हैं और सोचते हैं मैं क्यों प्रेशर लूँ, मेरे पास एक्सपर्ट्स हैं, वो प्रेशर लेंगे, मैं तो आई एम सरेंडरिंग टू देयर एक्सपर्टीज। तो इस तरह से मतलब एटीट्यूड मैंने रखा है, और फैमिली का सपोर्ट तो इतना रहता है कि आप बहुत मुश्किल हो जाता है इमोशनली फेस करना।
सर आई सैल्यूट योर स्पिरिट ऑनेस्टली, मतलब आपने जो भी किया, जैसे भी किया, बहुत हिम्मत है आप में और इस बात को कोई डिनाई नहीं कर सकता। और उससे भी ज्यादा हिम्मत आप में है कि आज आप इतने सारे लोगों के सामने आके ये सारी बातें हमसे कर रहे हैं। Thank you so much, Dr. Kailash. It was really amazing, and I really salute you. I am not really sure. Might have met my fair chance to meet the cancer survivors and patients, but बहुत हिम्मत चाहिए है, and आपने जितनी हिम्मत दिखाई है उसके लिए I really salute. Thank you, Mr. Kailash, आज हमारे साथ ये सारी बातें शेयर करने के लिए। एंड आपने इसी बात पे मुझे एक अगला सवाल दे दिया है मेरा, जो मैं चाहूंगी कि आई वुड लाइक Dr. Anil to actually kind of address this question. Mr. Kailash has already said it, I guess, twice or thrice, that this whole cancer thing kinds of drains a person financially. So how do you think that this, we all understand that this cancer therapies and everything is actually costly. So any suggestions you have as a representative from the pharmaceutical sector, that anything which can be done to, kind of make these cancer therapies a bit more accessible and affordable?
I think, Dr. Ruchika, you are asking a wrong person this question.
I'm sorry, I must have mispronounced it. I want to ask this to Dr. Anil. I'm extremely sorry.
No. You are asking a wrong question to Dr. Anil. That's what I'm saying. You should ask
Okay.
this question to the either Vandana madam or either me or me.
So whosoever feels
So,
that
Kailash
it's
sir, Anil sir, can I take on this? Because, for obvious reason, I think I should be answering this, isn't it?
Absolutely. Dr. Amol, please.
So, कैलाश जी, पहले तो मैं ये बताना चाहूँगा, शायद फिजिकली हम मिल नहीं पाए, बट आपके दुख दर्द को मैं एहसास कर रहा हूँ। शायद वंदना मैडम भी इस चीज़ को बहुत डीपली सुन रहे हैं। We are empathetic with this situation, बट ये
Thank
जो
you, sir.
फाइनेंसिस वाली बात होती है, ये बहुत बहुत ज़रूरी चीज़ है। मुझे ऐसा लगता है कि इट्स नॉट अबाउट ओनली द डॉक्टर्स जॉब। मैं ये थोड़ा यहाँ हिंदी में बोलूँगा बिकॉज आई होप दिस वीडियो गोज टू द मासेस। देखिए, मेरी ट्रेनिंग ऑल इंडिया इंस्टीट्यूट ऑफ मेडिकल साइंस न्यू दिल्ली में हुई है, जहाँ से मैंने अपना सुपर स्पेशलिटी किया है। हमारे वहाँ पे जो प्रोफेसर थे, आई वोंट टेक नेम हियर, बट ही इज़ अ पद्मश्री, बट उन्होंने एक हमें बहुत अच्छी चीज़ सिखाई थी कि कैंसर की फील्ड में आप बहुत सारी चीज़ें कई बार कर पाते हो, कई बार नहीं कर पाते हो, बट एक बात हमेशा याद रखना कि फाइनेंसेस की इशू को लेके मरीज को गिल्ट मत देना। वो चीज़ अभी भी दिमाग में वैसी है, एंड प्लीज़ गो थ्रू सम ऑफ मेरी जो पब्लिकेशंस हैं उनको देखिए। इनफैक्ट अभी एक बहुत अच्छा स्टडी जो फाइनेंसेस रिलेटेड है, जो TMH मुंबई से आया है बाय प्रोफेसर विजय पाटिल, जहाँ पे जो निवोलुमाब की जो दवाई है 240 मिलीग्राम की जगह वहां पे सिर्फ 20 मिलीग्राम यूज किया गया है, एंड इट इज इक्वली इफेक्टिव। रिसेंटली हमने भी अश्विनी हॉस्पिटल से 100 पेशेंट का डेटा पब्लिश किया है। आई होप वंदना मैडम इज अवेयर ऑफ दैट स्टडी। हमने सिर्फ जहाँ से हेड एंड नेक कैंसर की हम बात करें तो एक बहुत स्ट्रक्चर्ड डेटा, बहुत ही उम्दा डेटा जो क्लिनिकल ट्रायल फेज 3 हम डिजाइन बोलते हैं, वैसा स्टडी जो है TMS से आया है। बट हमने क्या किया, हमने पैन ट्यूमर जहां जहां इम्यूनोथेरेपी दी जाती है वहां पे ये डोजेस 1/10 यूज किए, और ये दिखाया है कि हमारे जो 100 पेशेंट की डेटाबेस है उसमें 46 पेशेंट्स को हमने लो डोज थेरेपी दी है जिसमें इट इज इफेक्टिव। तो ये जो सेंसिटिव इशू है जहां पे हम कॉस्ट कम कर सकते हैं, मरीज की जेब को सहारा दे सकते हैं विद इंटरवेंशन विच आर बैक्ड बाय साइंटिफिक डेटा। ये मैं ये नहीं कह रहा हूं कि किसी की मर्जी है और बस इतनी दवाई ले लो, नो, इट इज बैक्ड बाय द साइंटिफिक लिटरेचर। और ऐसा नहीं है कि जहां से ये दवाई बन के आई है अमेरिका में और यूरोप में लोग सफर नहीं कर रहे हैं। यस, दे आर ऑल्सो सफरिंग फ्रॉम द कॉस्ट इशू। ये वर्ल्ड वाइड प्रॉब्लम है। जिनके पास ऑब्वियसली अनलिमिटेड इंश्योरेंस फैसिलिटीज है, जहाँ पे कोई मनी का इशू नहीं है, अब करिए जैसे ट्रीटमेंट फैशन में होनी चाहिए, बट टेलर मेड अप्रोच करना बहुत जरूरी है। ये मैं इस मीडिया से बोलना चाहूंगा। जहां कोई इश्यू नहीं है, इट्स ओके, एवरीबडी इज राइट इन देयर ओन टर्म, बट पेशेंट सपोर्ट ग्रुप, काउंसलर्स, ये सारे लोगों ने मिलके ये काम करना चाहिए। ये सिर्फ अकेले TMH के स्टडी से नहीं होगा कि कोई और रिजल्ट से नहीं होगा। इनफैक्ट एक और रिजल्ट CMC वेल्लोर से पब्लिश किया गया है जहां पे उन्होंने बोला कि टेलर मेड अप्रोच करना ही पड़ता है, बिकॉज पहली साइकिल इम्यूनोथेरेपी की लोग ले लेते हैं, उसके बाद में आइदर दे विल बी लॉस्ट टू फॉलो अप, वो चले जाएंगे क्योंकि पैसा खत्म हो गया, ना ये ट्रीटमेंट पूरा हुआ ना वो ट्रीटमेंट पूरा हुआ। उसमें भी उन्होंने दिखाया कि यस, रिनल सेल कार्सिनोमा में ये थेरेपी इफेक्टिव है, एंड दे हैव प्रेजेंटेड ऑन इंटरनेशनल प्लेटफॉर्म। तो दुनिया में जो काफी चीजें जो चल रही है, ये मुझे ऐसा लगता है कि पेशेंट की वॉइस बननी चाहिए। ये पेशेंट ने भी अपने डॉक्टरों से डिस्कस करना चाहिए कि भाई मेरे पास इतना ही रेवेन्यू है, क्या ये मैं कर सकता हूँ। An unfortunate part is, on top of this, all this issue is, not a single insurance company is covering in India about the immunotherapy. वो कुछ मैनेज होता है थोड़ा बहुत इधर उधर करके, दवे एडमिशन और ये सब दिखा के उनकी जो अपर लिमिट होती है, बट इट इज अनसस्टेनेबल। It is not sustainable by any means, not any government, whether it is America, whether it is Australia, it is not sustainable. Mark my word. यहाँ पे हमें कुछ एवेन्यूज लाने पड़ेंगे। आई बिलीव इवन द कंपनीज विच हैव इन्वेंटेड दिस ड्रग, दे आर ऑल्सो कमिंग विद सम काइंड ऑफ पेशेंट एक्सेस प्रोग्राम। वो भी अपनी तरफ से जो भी उनकी लिमिटेशंस है, दे आर ऑल्सो कमिंग फॉरवर्ड टू प्रोवाइड दिस ड्रग्स in a bit of subsidies giving to the out of pocket patients. But ये सारी चीजें एक पेशेंट सपोर्ट एनवायरनमेंट में जैसे साइको ऑन्कोलॉजिस्ट की जरूरत है, वैसे ही ये डिस्कशन ओपनली होना चाहिए। जैसे कैलाश सर ने बोला, अभी मुझे बड़ा दुख हुआ कि एक डॉक्टर तो बोल देते हैं कि ऐसे ऐसे होना चाहिए, ऐसा ऐसा करना चाहिए, एंड दैट इज द बेस्ट अवेलेबल, बट इज दिस द बेस्ट फॉर द पेशेंट pocket also? One has to be very very careful, because on top of this illness, if we are also taking away the patient's lifetime, whatever the achievement in terms of finances are there, मुझे ऐसा लगता है कहीं ना कहीं we should be balancing out, because जो कैलाश सर की ये जो स्टोरी है, ये इंडिया की मुझे लगता है कि 95% लोगों की स्टोरी है, 95%। और यदि ये 95% लोगों की स्टोरी है, तो हमें इसके लिए सेंसिटिव रहना पड़ेगा, हमें इसके लिए आगे बढ़ना पड़ेगा। सॉरी, आई हैव टेकन हाईजैक द क्वेश्चन फ्रॉम डॉक्टर अनिल, बट वो अभी इसके बारे में और बात कर।
So definitely, sir. Anything you want to add to this, Dr.
My
Anil?
heart and my mind and everything. I have been publishing in pharmacoeconomics for long, and there are multiple avenues we have suggested. How can we reduce the cost of the ongoing, therapies, including targeted therapies, oral molecules, the immunotherapies. There are ways and means of doing the things and get the best and the optimum care for our patients.
Yeah.
Thank you so much, Dr. Amol. Please, Dr. Anil, please continue.
Yeah, thank you, Dr. Amol. I think all what you said absolutely resonates with me, and I think it's important that we nuance it from the local environment point of view. Two or three things which I want to add. A deep understanding of patient journey is very, very important, right from awareness to the outcome measurement. And that real world evidence and tailored approach will only come when we have the lot of local scientific data. And as I think some of the studies which Dr. Amol mentioned very nicely, the TMS study, the study from the CMC, and also the study from his own center, I think those are very important. Now, we definitely not only bring the life-changing medicines, but also we bring, as Dr. Amol rightly mentioned, affordability programs, the patient access programs, which are helping us to sustainably provide access in an equitable manner, particularly for the out-of-pocket patients. Two things which are important. I think we need to also enhance the advocacy on government prioritizing and ensuring that the government also enhances the funding for such kind of innovations. The second most important is the insurance covering holistically. So, as Dr. Amol mentioned, there are a lot of challenges, and I think it's important that the patient advocacy groups, the patient activists need to enhance their voice, that so that insurance program covers the totality of the care which is covered as per their program. And one important parameter also for the NGOs and the voice of healthcare, and also for all the patient advocacy groups, is how do we promote the health seeking behavior from the society, so that the early symptoms are not ignored and early diagnosis happens. If early diagnosis happens, there is a potential curative treatment options which are available if the diagnosis is early, so that the expenditure even will reduce because we are potentially giving the curative treatment with the better long-term outcomes. So those are the two or three things I just want to emphasize and highlight about. Thank you.
So, sir, you have, I guess, actually explained my another question which I had for you, that how do you think these PPPs can help in, making cancer care more affordable, which I guess you have somewhat explained that government actually needs to provide the fundings and the support. So thank you, Dr. Anil. That was really great. I guess Ms. Vandana is trying to add
Yes.
some points to it. So please go ahead, Ms.
Yes, yeah. So I want to thank Dr. Amol for raising that. I will. My heart went out to Kailash ji. Kailash ji, my heart bleeds with you. The drain on the finances. I'm also a very, very patient, very passionate patient advocate. I've been through the cancer journey, not the same cancer. I know how much it drains a family financially. I'm going to cite an example. So when we talk of tailored made approaches, what Dr. Amol said, are we also encouraging our treating doctors to have transparent, honest conversation with the person diagnosed? So just give me 2 minutes. I am going to just cite an example. I knew this wonderful man who was diagnosed with cholangiocarcinoma. He and I had long conversations, Dr. Ruchika, about, he knew he was dying. right? We spoke about end of life, we spoke about family, we spoke about everything. The only sore point that gentleman had was when I go and meet my oncologist, he suggests a medicine which is so many lakh rupees. When I ask him, how long do I need to take it or how effective it is, I get no answers. Vandana, I have two daughters. I have a wife, and I'm only 53 years of age. I don't want to be exhausting everything without knowing how effective or for how long I need the medication. This gentleman had cholangiocarcinoma, and he is forever etched in my heart because of the honesty of his conversation that he and I had. But this is carrying on from what Dr. Amol said. This is unfair. This is totally unfair on the people diagnosed. I'm not trying to irk anyone or not. I'm not trying to ruffle feathers. But till we can be honest with the families who are dealing with a diagnosis, we are doing great injustice to them. Great injustice, Dr. Ruchika. And I mean, I can go on and on and on. And this is also a part of palliative care. We need to empower them to know that they have the right to ask questions. They need not blindly follow what's being told to them. That's so important. And we need more voices for that. We are very few. I'm part with Dr. Mol, but yes, this is the need of the hour. It's not about us. It's about Kailash ji and his family. Are we giving them the space to, are we empowering them? No, we're not. It doesn't matter what the intent is. So yeah, I'm going to just stop at that.
I have to agree with Ms. Vandana, you, Dr. Amol, as well as Dr. Anil, that this is actually draining the finances of a family, and it actually leads to quite a tough journey, making it like a cancer journey is itself
See,
tough.
Dr. Ruchika, what I meant to here is in this world of making choices, and information technology. See, one has to just.
So till I guess Dr. Amol joins
Can
us.
I add one point here?
Sure, Dr. Bincy, sure, go ahead.
I
Sorry,
think
sorry.
Dr. Patel is back, so let him complete. Okay.
I mean.
Okay.
So what I'm trying to say here is everybody must read a book, and I have to keep that book, The Emperor of All Maladies, in my office or the OPD chamber, and is to gift this book to many of my patients. And I was really looking for someone who can make this book in Marathi or the Hindi with the permission of the author. The success of the America, what I realized through this cancer journey book is in the collaboration. It is not about the story of one person or 2% or the 3%. It is a journey together. Unless we heard or hear the voices of the patient, their relatives, their pain, their journey, their the holistically, this might lead us to somewhere some satisfaction in the day routine and seeing the PET scan with this bigger therapies or the the economical aspects of it, whatever the spend, and you see the scans at 3 months, 6 months, and 9 months. Oh, it's all good, it's all good. But is it a better good? It is a larger good? No. The larger good will only is going to come when we make him understand the facts. Most of the time, even this is not just one problem, it's not one end. There are many problems in the as a clinician also. Those clinicians who are into the giving the statistics very bluntly, or telling them this is much the life left, and and these are the chances, and sometimes the patient do take it negatively, and the doctor is negative person. That is what the connotation. So through this, it's not just a one-way problem. It is the complex situation wherein we have to unite together. What I feel is before coming to before seeing the patient, I wish my patient has already met Vandana ji. Also, simultaneously, my patient is aware of who is Dr. Bincy, and there are people like as Dr. Anil all around to look out for the best possible strategy for the managing the patient. Unless we do all these things, मुझे नहीं लगता कि हम कुछ खास achieve कर पाएंगे in true sense. What I'm saying is the larger good. The larger good will only come when the patient has some kind of a satisfaction holistically. Only seeing the scans in a with kind of a responses on the reduction in the redness of those PET scan कि गोला कम हो गया है, यहाँ से गायब हो गया है. In see the win over or the cancer के against पूरी तरह से सक्सेस पाना हमारे लिए अभी भी बहुत दूर की बात होती है, especially when it comes to stage 4 management and that to biliary tract cancer. तो ये सारे जो फैक्ट्स है, ट्रूथ है, ये हमें पता होने चाहिए. और जो मैं बोल रहा हूँ कि अमेरिका सक्सेस इज इन कोलैबोरेशन इन एवरी एस्पेक्ट. दैट जर्नी दी जहाँ पे ऑर्गेनाइजेशंस बनी, वॉर ऑन कैंसर वाज डिक्लेयर्ड, जो आजकल हमें अच्छे अच्छे रिजल्ट दिख रहे हैं. इट वाज द पीपल who were affected, they come together. The people like Dr. Ruchika, the people like Vandana ji, Kailash ji, they came together. They came together and they basically form a common platform. That's how the bigger things can be achieved in a good interest of the entire the humanity aspect. But I say it as a holistic approach. It's not just about the treating the disease or the scans and making those good environment here and there and कि आज तो मेरी बीमारी under control है, but how long that is going to get achieved, how many therapies we are going to give that. So एक comprehensive understanding यदि है और पैलिएटिव केयर शुरू से यदि अंडरस्टैंड पेशेंट करता है और जो जर्नी है वो पहले दिन से यदि हर एक चीज को मैनेज करके चले, तो पेशेंट हर दिन जो भी लाइफ है वो एक अपना लायन की तरह जिए, अपना अच्छे से खाना खाए और एक अच्छी सुकून से नींद ले along with the disease and the treatment. So we have to understand this, the coming togetherness, and that's how generally I don't say no to any such, the program which are outreaching to the patient. It's not about just the science, we have to make all our patient, what the one word Vandana ji has used is the empowerment. What is empowerment? The weakest link in entire the circle is the patient. Unless we make them the strong, because at the end of the day ट्रीटमेंट का पर्पस ही वो है कि उसको हमने स्ट्रांग बनाना है, वो सिर्फ दवाइयों से नहीं होगा. आई थिंक वी हैव टॉक्ड लॉट अबाउट द फाइनेंशियल एस्पेक्ट. we should move to this unending story here, but इस फोरम से मैं बोलना चाहता हूँ कि there are ways and means to deal with the financial aspect. I'm very happy that Psycho-Oncologist is there with us today, and Dr. Bincy. I really want some kind of facility to be in and around me when I am dealing with the patient, because we really need people like you. We really need people like you, and the journey of the patient can be made very comfortable with your interventions. Because what we have to understand, हमें यहाँ फिर से understand करना पड़ेगा कि जिस तरह से palliative care का role important है, उसी तरह से psycho-oncologist का भी role important है. सिर्फ डॉक्टर को लगता रहता है कि आई एम द बेस्ट काउंसलर, बट नो, इट्स अ साइंस. इट्स अ साइंस, इज अ प्रॉपर वेल डॉक्यूमेंटेड, वेल रिसर्च साइंस to how to intervene, how to get the patient out of the depression. how to get those anxiety related issues, how to tackle their sleep problem. So all these things can be dealt very uniquely, and I'm very happy today that to be part of this discussion.
Thank you so much, Dr. Amol. I guess I'll give the chance to Dr. Bincy. She wanted to add something in this whole discussion. Dr. Bincy, please go ahead.
Thank you, Dr. Amol. And I just wanted to add something to Kailash ji, because he said that because of the negative thinking, right? So it is completely normal to feel negative, and nobody can be positive at a situation like this. And see, even if I am diagnosed with cancer, okay, I will be negative, like because of the side effect, because of the situation. We all feel negative, and it is completely normal. And there is no scientific like connection, like if you have positive thinking, this like if you think positive, that is going to cure the cancer, nothing like that, okay. But if we are tend to think a lot of negative, and it could impact our sleep, and it will affect our other factors, other emotional aspect. For that reason, we say that we have to be more like positive, but that doesn't mean that you have to be positive all the time, and it is not going to be possible. And if you think that if you need any sort of help, okay, from me or anyone, just let us know, and we are ready to help you out. And like I really want to help everyone, and I know that I'm part of one private organization, but still we are doing a lot of like pro bono counseling and everything. And in case if anybody wants any sort of help from my end also, please let me know. Just drop a message to me, and I'm ready, and I'm happy to help as much as I can. And I just wanted to add that.
And from my side also, Dr. Ruchika, I'm intervening. This is for Kailash ji. Kailash ji, I will be very happy to have a conversation with you. It's okay to cry. Please know that it's okay to cry. And you can cry here also. We all understand your pain. And at any point, if you feel हम में से किसी से बात करके आपको बेनिफिट होगा, नहीं भी होगा, अगर दिल भी हल्का होता है, तो we are there for you through the journey.
Thank you so
Just
much.
wanted to
Thank
say
you so
that.
much. It's a disease where it is difficult not to cry, actually.
Absolutely, sir. Absolutely, sir.
And there is no denying in that.
Yeah, and it's okay to cry, sir.
It's not
you don't
that,
have to be a superhuman. Yeah.
You become less manly when you are, venting your emotions. So sometimes what happens is, आदमी होके रो रहा है, so that feeling usually, seeps in, and people try to hold their emotions and, just damn them. So that I usually don't do. And at times I'm unable to talk to my brothers. They are so emotional.
So that is where there are people like Bincy and I.
Thank you so much for being around.
So, and any time, sir, please take my number from Dr. Ruchika or Bincy's number. We are all trained in cancer counseling. You can reach out anytime.
मेरे डे केयर में जैसे ही वो पेशेंट इकट्ठा हो जाते हैं, 10-12 पेशेंट कीमोथेरेपी लगती है, most of the time the environment is happy because my day starts with some kind of a joke or some kind of there's one lady who comes with the the metastatic breast cancer with the brain mets, and she is almost surviving for 4 years plus now. So every time, and she was, initially deferred treatment, she lost to follow up, and then come with a very bad clinical condition. But whenever I meet her, I always say, "Hey, heroine, how are you?" And that one word used to make her laugh always, and the others too. And
one thing, sir,
in the OPD also, many a times some 3-4 patients are not in a in the happy state. So the very rudely I used to make a comment. It may sound rude, but making a joke that bhai bimari maine to nahi di hai. That just diverts the mind. And some of the tactics Dr. Bincy might be doing. So chota bota hum bhi psycho-oncology kar lete hain, madam.
Sir,
Only thing is that
we have to feel that. We have to feel as a person that what if I am there in that chair and receiving the chemotherapy. That's the only message, everybody has to take care. I'm getting emotional. Otherwise, I don't get. But the way the conversation is moving forward, and Kailash ji baat kar rahe hain, बस यही एक चीज है और यही एक जरिया है सर, हमें भी फील होता है, इतना ही मैं कहूँगा आपके लिए। एंड बस टफ रहना है, ठीक है,
थैंक यू
यही एक
सर।
तरीका है इसके ऊपर जीत हासिल करना। किसी के पास इतना है, किसी के पास इतना है, बट इतना भी है एक शेर की तरह रहना है।
थैंक यू सर। एक मैं बात करना चाहूँगा यहाँ पे
बिल्कुल।
कि अभी क्या होता है कि मेरे 2 नवंबर को एक्सप्लोरेटरी सर्जरी हो गई, तो एक लंबा सा चीरा लगाया मेरे अलोंग द एब्डोमेन टिल द मिड लाइन। तो उसके बाद उसमें टाँके लगे, तो और अनफॉर्चुनेटली जब भी टाँके लगते हैं तो खांसी उसका साथ मतलब जो है पता नहीं कैसे आ जाती है। तो उस समय मैं आई वाज ट्राइंग टू स्टे पॉजिटिव, और वहाँ पर मैंने एक छोटी 2 लाइन लिखी थी। तो ये था कि टाँके लगे हों बदन में और खांसी हो जाए, टाँके लगे हों बदन में और खांसी हो जाए, इससे अच्छा तो यार फांसी हो जाए। मतलब इतना पेनफुल हो रहता है कि मतलब सोचता है यार ये ना हो, पेट पकड़ के वो बैठा रहेगा, बेल्ट पहनाए रहते हैं, तो ही ट्राइज टू होल्ड हिज खांसी एंड बट ही कैन नॉट हेल्प बिकॉज खांसी इज ए रिफ्लेक्स। तो ये सारी चीज़ें होती हैं, तो फिर कोशिश करते हैं कि पॉजिटिव रहने की, लेकिन जैसे कि डॉक्टर वंदना कह रही थी और आप सभी कह रहे थे कि इस कंडीशन में स्टेइंग पॉजिटिव is not possible all the time, but of course deliberately we try doing it. So humor has a role, sir, in life.
या
And yeah.
बट कैलाश जी, मैं एक बात कहना चाहूंगा आपको यहाँ पे, जो
Yes, sir.
वंदना जी का फील्ड है उसके साथ में एक और फील्ड आता है पेन मैनेजमेंट का।
I was just going to come to that, Dr.
Yes.
Amol. See, I'm
हाँ,
just
तो
going to
कैलाश
jump
जी,
into it.
आज की डेट में इतनी दवाइयाँ हैं और देश के अंदर में इतने सारे लोग इस फील्ड में काम कर रहे हैं कि माय वाइफ आल्सो वर्क्स इन दिस फील्ड, दो शी इज इंटेंसिविस्ट, बट वो कहती है कि पेन इज द मोस्ट पेनफुल थिंग इन लाइफ। और हमारे यहाँ एक टॉलरेंस जो है ना, हमारी जो संस्कृति में बैठ गया है, हमारे एक स्वभाव में बैठ गया है, हमारी ट्रेडिशंस हो गई हैं कि पेन तो भैया पार्ट ऑफ लाइफ है। नहीं, नहीं, बिल्कुल नहीं, बिल्कुल भी पार्ट ऑफ लाइफ नहीं है। यदि डॉक्टर ऑल अराउंड पेशेंट को 100% पेन रिलीफ नहीं दे रहे हैं तो मैं बोलूंगा इट्स अ फेलियर, इट्स अ सिस्टम फेलियर।
Absolutely.
फौज में हम लोग बोलते कमांड फेलियर, है ना, मतलब कि आपको आपको आता ही नहीं है। इस लेवल तक का हमारा कमिटमेंट जाना चाहिए। एंड आई थिंक मैं वंदना जी को रिक्वेस्ट करूंगा इसके ऊपर और कुछ बात करें यहाँ के लिए, पेन मैनेजमेंट।
Dr. Ruchika, can I?
I would actually not like to stop you, but I'll request you to keep it a bit concise.
Very
We have
short.
already exceeded the session
Absolutely.
by 25 minutes.
Absolutely. Absolutely. कैलाश जी, पैलिएटिव केयर का एक इंटीग्रल पार्ट है पेन मैनेजमेंट, पेन रिलीफ. पेन रिलीफ इज ह्यूमन राइट. It's a human right, and you never have to be in pain irrespective of किस स्टेज की, किस इंटेंट के साथ आपका ट्रीटमेंट चल रहा है. ये आपका हक है टू आस्क, टू डिमांड फॉर पेन रिलीफ, कैलाश जी. एंड फॉर सम रीजन अगर नहीं मिल पाता तो प्लीज मेरे पास, मेरे से कनेक्ट कर लीजिए. मैं आपको 100% कहीं ना कहीं से पेन रिलीफ दिला दूंगी. जो पेन होती है सर, वो इफेक्ट्स द क्वालिटी ऑफ लाइफ, एंड यू डोंट डिजर्व दैट सर. मैं तो ट्रीटमेंट की बात ही नहीं कर रही. यू शुड नॉट बी इन पेन. बीमारी से ज्यादा जो पेन होती है, अगर आप पेट पकड़ के बैठे हैं, इट्स नॉट द डिजीज, इट इज द पेन दैट्स कॉम्प्रोमाइजिंग योर क्वालिटी ऑफ लाइफ. वो नहीं होना चाहिए. और डॉक्टर अमोल ने जैसे बोला है, आजकल एक नहीं, आजकल मल्टीपल ऑप्शंस हैं. इंडिया में मॉर्फिन, फेंटेनिल सब कुछ मिलता है. मॉर्फिन इज सबसे सस्ता पेन रिलीफ अवेलेबल है सर. और पेन रिलीफ से आपकी क्वालिटी ऑफ लाइफ बेहतर होती है. एंड थ्रू दिस फोरम आई ऑल्सो वांट टू टेल पीपल कि जब हम मॉर्फिन की बात करते हैं, मॉर्फिन का मतलब ये नहीं होता कि वो डेथ को हेसन करती है. एक मिसकंसेप्शन है कि मॉर्फिन लेंगे या पेन रिलीफ लेंगे हमारे दिमाग पे इफेक्ट करेगा, हम सोते रहेंगे. जब आप पेन आपका कंट्रोल में होता है तो आपकी फैकल्टीज भी आपके कंट्रोल में रहती हैं. So this misconception, we need to do away with that, and we need more voices. So Kailashji, pain relief
Well,
is your birthright. It's a
thank you.
human right. Ji sir.
Thank you so much. Although I wish to really keep on talking about this thing, about everything which is actually necessary, because we are kind of explaining and talking about all the components which are important when it comes to cancer care. But unfortunately, we'll have to kind of come to the end of the session. And because I don't want any one of the listeners to go through all of what everyone we have already talked about, being diagnosed with cancer or going through the treatment, the pain management, and everything. So I'll request Dr. Amol to kind of tell us what we can do to kind of prevent ourselves from getting cancer. I guess prevention is better than cure, and that's the simple mantra I follow in my life. So, just for everyone's knowledge, so if you could just explain some preventive measures. Over to you, sir.
So, see, it's again a very big science. So we don't have much of well-established strategies to prevent the biliary tract cancer. There are a lot of research happened, and but though we don't have any concrete evidence or the guidelines for preventing it. But certainly, having said that, first I will just cover with the screening part of it. There are trials and positive also and the negative also. That means the results were in for the screening, and there were results were not for screening. In Chile, Chile, whatever the pronunciation in that country, as a mandate for the country, they did the prophylactic removal of the gallbladder, and but one of their trials supported its use, but some of the studies are against it. It doesn't help much. So, like very high risk patients are there, wherein like the people of more than 50 years age, female gender, and obese patients. They have the higher risk in these countries, and such kind of high risk patient, high risk normal population can be screened. Then there is a lot of again controversy against bile stones and gallbladder stones and all kind of things. So it will be a very complex subject to make the understand the general population as such. But one of our doctor from the forces, Dr. H.P. Singh, did a very good study at Lucknow, and he showed that the ultrasound can be used as a screening modality to pick up the gallbladder cancer early. So it was just a pilot study of around 900 patients, and when you really have to do the such kind of a screening test, it is in the patient has to be in thousands. Uh, I had the opportunity to analyze that data and publish it on his behalf. So there is a scope of doing a lot of new research in this field for the screening as such to pick up the disease, like we have a mammography in the breast cancer, low dose CT scan for the picking up the disease of the lung cancer early. So there are avenues of it. For gallbladder and the biliary tract cancer as such, the risk factors like water contamination with the arsenic is one of the suggested or the possible risk factor. Then the consumption of the mustard oil in this region is also one of the suggested risk factor. But then the causal association and to reduce at the national level, like and saying no, especially to such kind of food habits and all, it's very difficult. There is a need to see these kind of aspects and also the baseline genetic risk. We are also evaluating such kind of risk factor at our center. Such studies, they do take a lot of time. Meanwhile, a basic advice to everyone through this forum is maintain your healthy lifestyle, do regular exercise, and avoid the addictions, whatever kind of addictions you have, alcohol or the smoking, tobacco chewing. If we do all this lifestyle changes and eating a good Indian meal, in the Western literature, they all say about the Mediterranean diet, and there are studies done and they publish in the NEGM and the bigger journals about the Mediterranean diet. What is Mediterranean diet? What the Indians are eating with all those colorful salad with the all three colors and four colors are there all the time. All seasons we have the salad and the vegetables and the vegetarian diet, and restrict your red meat. If you do all such simple measures, I think we are going to reduce almost 30% of the cancer in general. For biliary tract cancer, to pinpoint a specific risk factor, we have a long way to go.
Can I quickly jump in, Dr. Amol? I think for everyone's information, Dr. Ruchika, may I? You're mute.
Yeah. Go ahead.
Go ahead.
So a couple of people that I've been interacting with, they were diagnosed with hepatitis, and then later they got, a cholangiocarcinoma. So are the people with hepatitis predisposed, or how does that work?
So same thing at the hepatitis, whether it is B or E virus. But then again, the causal relationship and the strong association with this infection is there are some studies which say that there may be the association. One has to understand here the two different words. One is association and one is a direct causal link. So the we say when the two common things are there, and in this particular group of the patient, like if there are 100 patients of hepatitis B virus, let's take in that way. So in this hepatitis B virus, certainly if the patient has gone into the cirrhotic phase, मान लीजिए उस cirrhotic phase के बाद में sizable number of the patient will develop the hepatocellular carcinoma, and some patients might develop the cholangiocarcinoma. So there is a link, but then the association with not every patient is going to develop this. Then even for the gallbladder cancer, one of the proposed theories about the typhoid fever. So in India, because of the poor quality of water and all, in the past, this was, in fact, there are some association studies which have shown that those patients who suffer from the typhoid fever, they also have an increased chance of having the gallbladder cancer. This is a very complex subject to understand. About the meals, about the heavy fatty meals, and the obese patients, they have the increased risk, like the relative risk of about 1.5 to 2. That means 2 times you have a more risk if you have an obese person as compared to the normal body weight person. So these are all association studies. Direct causal link or the studies we don't have, but certainly yes, what you said is right. Hepatitis B virus, C virus, then typhoid fever, and some of the flukes. Just when in India, we don't see the parasitic infections. They are the schistosomiasis we call, and some of the parasites, they do have a tendency to stay for a longer time in the biliary tract. They are seen in some of the South American countries also, and African countries also, and some part of Malaysia and all. In those countries, cholangiocarcinoma extra hepatic, because the parasite, they do stay in the bile duct. So it's a direct relationship of having these parasitic infections and having the cholangiocarcinoma. What I mean to say, in our context of our country, there are a lot of studies about the organophosphate, studies on the levels of the arsenic in the drinking water. There are a lot small. There are studies. Those sample sizes small from the BHU. What they did is that a very beautiful study. They had analyzed the blood levels of the organ of hospice and the
I'm
same level.
sorry, Dr. Amol, I'm cutting you in between, but we have actually exceeded the session. So if you could
Agree,
just
agree.
keep it
No
a
problem.
bit concise
No, no,
and
it's fine. But my
just let
point
us
is that
some.
it's a very vast subject. We can talk
I
this
totally
subject
agree, sir.
maybe
This
after
is
some
something which
maybe in
could actually
some
we can go
other
on for talking about it
forum.
for
Yes.
hours. Like I am not really sure about how many hours even I would need to
No,
kind of
no problem, no
explain
problem.
cancer.
When it comes to gallbladder cancer, sometimes I lose my breaks. No problem.
No, so I can definitely understand the love you have for this to treat this kind of cancers. I can definitely get it, and it was really, really insightful. And I have learned a new perspective talking to everyone over here. But because of the time limitations, I really need to kind of end this session. And I would really like to thank everyone, and a special thanks to Kailash ji. Ragi, you have really joined us today and shown us a journey. It was really amazing to have you with us. We totally
Thank you
understand
so
it's
much.
not easy, but people like you, people like all the cancer survivors, they give us an energy to kind of keep going forward. Thank you so much. Thank you for every panelist who has joined in us today, for being there with us, for being part of this whole discussion and actually sharing amazing insights where we have not just kind of discussed the similar questions which we discuss every time, the science, causes, treatment, diagnosis, and rather we have gone forward to discuss about the fundings, the fundraisings, and the palliative care, pain management, the psycho-oncologist. So everyone plays an important role over here, and thank you all the speakers for joining us today. Thank you really much, and it actually means a lot. I appreciate everyone's presence, and with that I would like to say thanks to you, and I hope to meet you all again really soon on some other topic. So thank you, everyone.
Thank you so
Thank
much.
you. Thank you.